Hello and welcome everyone to today's office hours webinar, National Schwartz Rounds on Substance Use Disorders, Sharing Our Experiences. I'm Stephanie Adler-Yuan, Director of Education and Training at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national leader in the movement to make compassion a vital element in every patient-caregiver interaction. We're pleased to offer this complimentary session for our members. Before we begin the formal presentation, we'll go over a few details about the webinar. Today's program will be 60 minutes long. The first 45 minutes will consist of a presentation, followed by a 10-minute question and answer session, during which we'll ask you to submit your questions and share any experiences that you'd like to share with the group about your own National Schwartz Rounds experience. Today's program is being recorded and will be available on the Schwartz Center's website a week after the session. Please note that attendees are participating in listen-only mode, but can interact with the speakers by using the questions pane, which should be appearing on your screen. If you have any questions or comments during the session, please type them into the questions pane and send them to us, and we will address as many of them as we can at the end of the presentation. Finally, as you exit the webinar, you will receive an electronic survey that will ask you to take a minute to complete so we can capture your assessment of today's program. Your feedback is really important to us, and we hope you'll have time to complete the assessment. And now, it is my pleasure to introduce today's speakers. Dr. Beth Lown is an Associate Professor of Medicine at Harvard Medical School and the Medical Director of the Schwartz Center for Compassionate Healthcare. Welcome, Beth.
Thank you, Stephanie. I'm very happy to be joining all of you here today.
And our second speaker today is Dr. Stephen Post, who's the founder and director of the Center for Medical Humanities, Compassionate Care and Bioethics at Stony Brook University School of Medicine. And he's also the Schwartz Rounds facilitator at Stony Brook Children's Hospital. Welcome, Stephen.
Thanks for having me, Stephanie and Beth. It's a delight.
Great. So without further ado, I will hand the program over to Dr. Lown.
Well, thank you all. And thanks to everybody out there who offered the Schwartz Rounds on the opioid epidemic. Today we'll hear a little bit about the experiences of members who offered the rounds on this topic. And honestly, I always wish I could listen in on so many of these rounds. But we will hear from Stephen, and he'll share his experiences. And I hope that, as Stephanie asked, that you'll use the chat box to share your own brief comments, maybe even tweet side stories and your questions throughout this webinar. After Stephen speaks, I'm going to show you the results of the evaluations we received from our members about these rounds. So our goals for the rounds are, for these, the webinar that is, was to really just learn about the experiences of our members here. And most of this will be through Stephen's experience as a surrogate for all of you, and also through the evaluation summaries. And we will think a little bit about what these insights mean. But first, I'd like to set the stage for you. Let's go to slide 6. As you know, the opioid epidemic continues, as does the rate of deaths from opioid-related overdoses, especially fentanyl and heroin. According to the Centers for Disease Control and Prevention, an estimated 59,000 to 65,000 people died from opioid overdoses in 2016. And you can see from that slide, the rate of rise of that curve continues to steepen. It is a startling statistic. Opioids as a cause of death far surpassed death due to motor vehicle accidents, which in 2016 was a little over 37,000. In 2016, opioids killed more people than all of the U.S. soldiers who died during the entire war in Vietnam. There are, of course, many reasons why this is happening, and perhaps you're already talking about what you can do about it in your own communities. I hope so. It's hard to grasp the enormity of this tragedy from the statistics, but it's not abstract when you see people across all demographic characteristics coming into your emergency room, overdosing, being brought back to life, returning to the streets or homes, continuing to use drugs, and it's not at all abstract. When you have a loved one, a family member, or a friend who's suffering from a substance use disorder, and I imagine that some of you may very well have experienced this. It's not abstract when you're experiencing their desperation and their despair, as well as your own. And it's never abstract to watch someone die. It's not an abstraction when you feel frustrated and helpless, unable to fill your calling to help and to heal. But what we don't see are the millions of people who are in recovery. And the fact of the matter is we do have effective treatments for opioid use disorders. There are a lot of barriers to accessing these treatments, but recovery is possible. And we need to hear more stories from people who are in recovery. But I'd say that even though we know that opioids and these other substance use disorders, these are brain-based disorders. They have terrible behavioral manifestations, but it is extremely difficult to reverse the social stigma associated with substance use disorders and with opioid use among the public and in healthcare facilities as well. I mean, like others, many healthcare workers feel that substance use disorders are a personal choice, a sign of moral weakness, of selfishness. But in our professional roles, we're really called to take care of everyone. So how do we manage the impact of witnessing so many preventable deaths? And how do we manage the impact of our sense of frustration, sometimes even our anger, when people seem unable to care for themselves? How do we sustain our compassion in the face of an opioid epidemic? So these intense thoughts and these emotions are the reason we invited our members to offer Schwartz Rounds on this epidemic. And in preparation for the initiative, we partnered with an expert advisory group that included members of the American Society of Addiction Medicine, the U.S. Substance Abuse and Mental Health Services Administration, the Mass Department of Public Health, and many clinicians with expertise in this field. And as you know, we prepared a package of resources that included a facilitation guide with learning objectives, facilitation suggestions, a compendium of resources to offer to your communities, and a case with provider and patient narratives that could be read aloud unless you wanted to use a local case, which many of you did. And we also provided the evaluation form so we could learn from you and get some of your feedback about what you thought the impact of these rounds were on participants. So let's go now to the next slide, slide 7. The goals of these national rounds were to provide a safe forum to discuss the emotional and psychological impact of caring for patients with substance use disorders, to talk about the impact of stigma and stereotypes on the care that we provide, to discuss strategies to help caregivers sustain their compassion and resilience when caring for patients with this illness, and also to initiate wider organizational conversations about how to improve our care for this population of patients. So let's go now to the next slide. And I'm going to turn the discussion over to Stephen to describe his experience offering the rounds to his community. Stephen.
Thank you, Beth. Hi, everybody. I will try to be brief. I think we've allocated about 10 to 12 minutes. And my guess is that what we articulate will resonate with many of you who have had similar kinds of experiences. We had our Schwartz round on the topic, what happens to compassion during an opioid epidemic, caring for infants of deceased mothers. And our particular scenario, clinical setting, was in the maternal opioid management service at Stony Brook University Hospital. Now the case, I'll just touch on it because these are really less important than the responses of professionals to what they experience. But there was a pregnant woman who required addiction medicine services. She gave birth to an infant dependent on opioids who vomited, sweated, experienced diarrhea and convulsions for an estimated 5 days of classical neonatal abstinence syndrome. Well, the mother left the hospital a couple of days after birth and went home, and promptly, within about 24 hours of going home, overdosed and died while the infant was still in the NAS nursery at the hospital. So that's the quick vignette. We had a wonderful clinician, Dr. Gary, who's the supervisor of the opioid management service. And he spoke first, as typically would be the case for 5 or 7 minutes, really from the heart, about how he struggles to maintain his professional identity. It's so easy to become jaded and moralistic and judgmental with regard to these women. He acknowledged his mixed feelings at times. He tries not to think about this really on a moral paradigm. He found a lot of benefit in appreciating addiction as a disease, drawing on the science, where you really see how out of control people get with respect to frontal cortex and self-management. He talked about how sometimes you hear language that's dehumanizing and depersonalizing, sometimes even derisive within earshot of these women, and sometimes even demonizing, if you will. So that's always a tendency in these settings. And he just pointed out that every day when he comes to work, he has to be very mindful and attentive about maintaining empathy, about responding and not reacting, about being a generous listener, about being accepting. But on the other hand, it's a difficult task he has every day, and he contrasts these women with their addictions and then the birth of their children. So he goes through a lot, and he appreciated an opportunity to speak about all those kinds of feelings that he would otherwise leave out in the parking lot before he walks up the stairs into the hospital. There was another person on our panel, a social worker by the name of Stephanie, and she used the word acceptance a lot. She's always trying to save both mother and child, and that's really the goal of the management service. But she gets very, very frustrated because Suffolk County is, well, it's a little bit like Hamilton County in Ohio, for any of you who are there. It's the #1 county in New York for opioid addiction and opioid overdose. I don't know what it is. We're kind of remote from New York out here. It's an island culture in certain respects. There's a high volume of cases. There's actually, I think, twice as many cases as the nearest competing county, which is Queens. So that gives you perspective. And she was really worried about the fate of the child. What will happen to this child, especially because they had lost the mother, and she felt very badly about the loss of the mother. Maybe they could have done something a little differently. Maybe they could have kept her in the hospital a little longer and worked with her in some more effective way, but it didn't turn out that way. She talked a lot about the role of the grandparents. The grandparents were actually really happy to be taking this child on. They were already raising the child's 11-year-old sibling. But, you know, a lot of anxiety about just where a child without a mother is going to be raised, and hoping that the quality of life in the wider family would be good. So there was just a lot of frustration, not anger, but frustration about sort of, you know, feeling the futility, the onslaught, almost the tsunami here of this problem. And it just kind of comes right through the back porch and blows everything over in its path. And that's how this team lives every day, day in and day out, 24/7. And it's a very challenging occupation for them. There was a nurse named Lisa there, and she runs the NAS nursery, but she also interacts with addicted mothers and the families to a large degree. So what she was really interesting, because her contrast was like really graphic. You know, it was like the contrast, you know, between, okay, the birth of a child. All right, you know, child's got issues, but it will clear up. But the birth of a child, a wonderful, glorious thing. And then at the same time, the death of a mother. And, you know, it's just the sort of graphic polarity of those two things that was on her mind very much. And she was pretty emotional to the point of tears about this. You know, on the one hand, she's frustrated, and she'll talk about maternal fetal conflict, and she'll have some anger and some blame. But in the end, you know, she forces herself to control those kinds of stereotypical tendencies, and she really attempts to interact with equally regarding love and affection for the mother, for the baby, and for the family. She maintains hope for everybody, although she did say that, you know, when you come up those back stairs again and you work in this field, you kind of feel like you're going into Dante's Inferno, where the sign says, abandon hope, all ye who enter here. So she was very sad with the loss of the mother. She remained supportive of the mother as best she could, but again, she felt a little compunction, a little unease, because maybe they could have done more with the mother when the mother wanted to go home. She was very upset with that outcome, but she was glad that the baby recovered, that the family seemed okay. And interestingly, she commented, as did the social worker, Stephanie, that the grandparents were actually almost seemingly relieved. Remember, seemingly relieved at their daughter's death. I know that's a hard thing to say, but that was what they said, because they'd just been through so much with their daughter for so long, and now they just felt, well, may she rest in peace. And by the way, Lisa, the nurse, had intuited really pretty early on that the mother was not going to make it, so she wasn't shocked by all of this. Now, just, you know, opening it up then, as we do, to the general group, we probably had about 80 people in that room. You know, they all acknowledged their mixed feelings about these experiences that they're having. Their biases were discussed. They invited a lot of dialogue. They felt very relieved to be able to put some of these feelings out on the table for their peer respondents. They wanted to counteract these ambivalencies. They wanted to process a lot of things so that they could continue to do their work in a meaningful way. You heard a lot about how they felt about addiction, you know, because Suffolk County is, like I said, it's like Hamilton County, Ohio. You know, it's just you know, it's amazing how much of a problem this is. So a lot of them actually would do some transference, and they'd talk a little bit about some of their own family situations, maybe a adolescent son who's got a problem, or someone else they know very closely, and it was very moving. They had hope, but again, you know, a very realistic hope, not just an optimism at all, but just, you know, kind of they had come to a realistic hope, really in part through our Schwartz Rounds, about maintaining their professional identity and their empathy, even though they know that this is going to be a long haul and not an easy one. It was a real safe environment. We emphasize in our rounds a concept that Parker Palmer had created down in Philadelphia, the Quaker writer, a circle of trust, you know, responding, not reacting, not having easy answers, assuming that somehow people have the answer within, and so if you ask the right question, you can kind of tease it out, and that works pretty well. There was a lot at the end, a lot of desire to learn more about the experience of opioid-addicted mothers, you know, really where are they coming from, what's going on, and then suddenly the themes shifted a lot to kind of the elements of our culture and our society that maybe contribute to this problem, like the absence of community, the absence of purpose, the loss of meaning somehow in our times, the feeling of anxiety about the future, the state of our culture, and also spirituality. I mean, you know, people felt that somehow a lot of this was a kind of, what should I say, a sort of surrogate spirituality. People just, you know, desperate for meaning and trying to find it in all the wrong places. So I thought at the end, it took a very more empathic turn because people were getting creative about understanding the larger context. And in the end, I think they went away feeling that they'd had a very thorough conversation, that they processed a lot of feelings, and that they could proceed with the day more effectively. Is that okay?
It's painful. Thank you, Stephen. It's painful to hear the whole thing, really, the stories, and yet that young woman. And the challenges, these conversations really touch the heart of who we are. Why are we here? Why are we drawn to this work? How can we give the best of ourselves to everybody we touch? How do we face our own biases and stereotypes? How do we uncover them? They're so ingrained. They're so socially ingrained. And it sounds like you had just a really important conversation there. I can, if you'd like, I can go ahead and share some of the results of the evaluations that we received back from our sites. And we can continue the conversation about your round, Stephen. I'll show this and then we'll hop back and forth, I think, between some of the issues that the evaluations raise and your own individual experience. So
yeah, that's just fine.
Yeah. I mean, as you know, we sent out these surveys to the sites that did the rounds. And this is what we got from the quantitative portion of the surveys. We had a lot of people respond. 106 sites participated in these rounds. And we received evaluation forms and comments from 66 sites. So you'll see the number of comments we received and responses for each of these questions. And you can see that really the majority of people felt that they did have some new insights into the experiences of patients who are suffering from this illness, and and were offered an opportunity to reflect on their own attitudes towards patients with substance use disorder, opioid use disorder, which I think is really important because that was really what we were trying to do. We were trying to open the door, open the heart so that we could really just look at ourselves and the assumptions that we hold. And I think often there's a conflict between what we know about the science of substance use disorders, opioid use disorders, and how we feel about them. And it's so difficult to sort of reconcile the difference between our sort of ingrained assumptions and what the new science is really telling us about this. So that opportunity that we were able to offer, and to offer as community discussions, I think was very, very important and very helpful. I guess I would say that there's still, by far, the vast majority of people responded positively to this, but 86% said they had learned strategies to sustain their compassion and resilience while working with this population of patients. A little bit more, 88% said they wanted to learn more. They were motivated to learn more, how to improve their care, and 81% said they plan to discuss strategies for how to do this with other members in their practice or department. So these were encouraging, we thought. If we go to the next slide, you'll see a little bit of the qualitative theme. So we asked some open-ended questions, and I was really appreciative. You know, often we'll ask open questions and people skip those, but we really got a lot of comments here. And so we boiled the comments down into 6 themes and a set of needs that we identified. So one of the key themes were perceiving suffering, being aware of judgment, offering compassion, and these are sort of global overarching themes. And this theme pertained to the importance of understanding the patient as a person within his or her social context, his or her real-life experience, including the antecedents, what had come before, what we were seeing in the hospital, the impact of patients' substance use on them, on their families, on their lives. And so some examples of what people said on these evaluations were things like, remember that when you're treating a substance use disorder, you're treating the whole family, not just the individual patient. Others said, one other person said, I'm going to keep in mind that patients who struggle with opioid addiction didn't plan on becoming addicted. Be compassionate. You never know what trauma someone has experienced. And finally there, but for the grace of God, go I. The next theme was about teamwork and team support. And this is about the importance of becoming more aware of other team members' perspectives, perhaps their own circumstances, the desire to reach out, to seek and receive compassion from other team members, to try to feel less isolated, to reach out so that they felt less alone in trying to deal with the impact of caring for patients with substance use disorders. And here we heard things like, in listening to my colleagues, I recognize my own biases and judgments, and I want to decrease these. Another person said, I'm planning to reach out to colleagues for support, especially when I'm frustrated. Another said, weaning pain medications really needs to be a team approach. And yet another expressed her sense of conflict. I always feel stuck between the provider writing the prescription and the patient. So here's someone being caught in the middle, trying to really being the mediator between the patient's needs, the patient's illness, and the person who's prescribing medications. So there's no easy answers here, and we did see conflict. The next theme was about being more open to discussion about substance use disorders, and about feeling really a personal shift and trying to figure out how can we widen these kinds of discussions. One person said, I really want to discuss more openly my professional challenges with regard to this population. I know that these challenges that I'm feeling are also being felt by my colleagues. Another person said, plan to work with colleagues to develop clear institutional guidelines for opioid prescribing. And another said it's really great that we're talking about this as a group within our community. So then the next theme was about self-awareness, and this was about becoming more reflective as a caregiver, trying to understand one's own emotions and biases. And honestly, we're all biased. If you're human, you have implicit bias, as we all know. Trying to be less judgmental, trying to understand how does that happen? How can we be self-aware, being within our own minds and being able to step outside and realize when our assumptions are clouding how we're interacting. And that really was related to understanding substance use as a chronic illness that we cannot control. And I think, you know, in my experience teaching motivational interviewing, I think that's the hardest thing for people to grasp, is the idea that we can't control the actions and behaviors of others. We can support, guide, offer hope, but basically our job is to help people find within themselves the capacity to change and to find that kind of support. So in this theme, we heard both positive and conflicted comments. Sometimes listening and planting the seed can be enough. And then one person talking about self-awareness said, I've often asked, why do we keep throwing away resources on these people who won't take care of themselves? And I said that until actually someone who was close to me overdosed and died. So here, a powerful example of someone who made this shift under the most dire and personally painful circumstances. So if we go on to the next slide, we'll see a couple of other themes. One was person-centered approach to the patient, and here, this is where we heard more about the need to enhance our own interpersonal skills, listening goals and preferences rather than imposing our own, advocating for patients, holding out their hope for recovery, establishing trust, trying to take others' perspectives, practicing patience and honesty. And again, examples, listening to my patients, I see that their substance use disorder is a chronic disease, a disease they didn't choose, but that can be treated. Another person said, perhaps I need to have the courage to be more direct about stating the fact that this person has a substance use disorder, that they have a problem with addiction as a form of showing compassion. Another said, I need to be an advocate for speaking up and involving the patient, pain and substance specialists in the plan of care. And finally, one person said, we have to always keep the patient engaged. Let him or her know you're not going to give up on them. And then that final theme here is the impact of patients with substance use disorders on staff. And in this theme, we read comments about the negative emotions, the frustration, the anger, the anxiety, the stress, uncertainty, helplessness, a sense of failure. These are all the negative emotions that can sometimes lead us towards being defensive and then flipping quickly over into the kind of anger that really is just a symptom of the underlying frustration, sense of moral distress. And we read comments, very frank and honest comments about what it is that puts caregivers on edge, their experiences of feeling that they're being lied to, that they're being manipulated by people who are actively suffering from these disorders. And then there was an interesting comment, you know, about one person's uncertainty, about how can we shift from this huge campaign that launched pain as the fifth vital sign towards more realistic expectations. This person said that in the cancer world that I was trained in, we were told that no one needs to experience pain. How do we change that offer? And then others spoke about learning and trying to learn to live in the gray area, that things aren't black and white, that we need to be comfortable with holding out hope even when we ourselves are uncertain. Complex emotions of caring for these patients. On the final slide, I'll just show you some of the needs that participants identified, and there were a lot of them. People wanted more skills in how to do motivational interviewing and other kinds of counseling skills. People felt the need to teach some of these skills for their frontline staff when they interact with patients with substance use disorders. They needed more information about how to sustain self-care, self-compassion when managing patients with substance use disorders. They needed more information about the nature of this illness, the physiology of it, about the physiology of pain, about evidence-based best practices for managing pain with opioids and without opioids using alternative methods. And a lot of questions about how do we manage patients with chronic pain who also have substance use disorders if we're not going to prescribe opioids, or if we decide we will, what do we do? What are some best practices there? What are some of the treatment options available? Holistic, integrative, other pharmacologic treatments. What are the community resources? Governmental policies, how do we influence those? How can we develop and use functional instead of quantitative pain assessments? And can we develop protocols for managing opioids in all kinds of venue settings, contexts, and during care transitions? And where can we learn more about family support programs? Families are desperate out there, often given just lists of clinics to call, resources to locate on their own. It's completely and totally overwhelming. So these were some of the needs that were identified by people who participated in these rounds. We did share this with the American Society of Addiction Medicine. We will follow up with them about how they're planning to follow up on these needs. They will be posting our report on their website and have promised to share it internally amongst their society members. And hopefully they'll work on addressing some of these issues that were identified. So I think what I would like to do is look at some of the questions, and then we can perhaps look at our last slide about what we can do to sustain ourselves and our compassion. But let's try to address some of the questions first, and then we'll end up with that last slide. Stephanie, do you want to start fielding some of those for us?
Yeah, sure. We've had a few questions come in over the course of the webinar, and I would encourage anyone who either has a question for Beth or for Stephen and wants to share that, please feel free to enter that in your questions pane. And also, if you were one of the 100 Schwartz Center member organizations who participated in this national rounds, we would love to hear a little bit about your experience. So feel free to use that questions pane to write a couple sentences about what the rounds was like for you. But in the meantime, yeah, we have 20 minutes left. Let's see if we can get to some of these great questions. So first, I'm going to go with this. I'm going to start with the specific. We have a question for Stephen Post from one of our participants, which is, were any inpatient addiction services offered to this mother who went home and overdosed? And if not, I guess if not, let me see, sorry, who went home and overdosed while her baby was undergoing withdrawal, and if not, what could be done? I guess I would ask you, Stephen, that's a classic type of question that often comes up at Schwartz Rounds when we think about what happened in the course of treating a patient and wonder what sort of measures were taken and what might have been offered to the patient or to the family. So I guess my question for you, Dr. Post, to sort of take that one step further is, were there people during your Schwartz Rounds who were inclined to ask those types of questions? Around what exactly happened over the course of caring for this patient? Was there a feeling amongst the team that something more could have been done which is often one of the challenges we see in all of our Schwartz Rounds cases, and also I think particularly in these substance use related cases.
Absolutely. You know, I think one of the sentiments expressed was, well, was the mother abandoned? Of course, she really wanted to get out of there. She wanted to get home and presumably satisfy her addiction. She was lucid of mind, I guess, in all of the technical, very superficial ways. She was quote unquote autonomous and could vote with her feet, which is pretty much what she did. It's not as though people didn't try to invite her to get more help on the spot and maybe stay a little longer, but that's always a challenge because you know, you want to respect people's autonomy, but you can also abandon them in the name of autonomy. And so I think that was really where one of the painful affective elements rested. You know, did we do enough? Could we not have done more? And that always does come up. I mean, you know, we had 10 seconds or less a case of a 17-year-old who refused chemotherapy because he'd been watching a lot of videotapes, and Child Protective Services said, well, he's almost 18. He came back a month later. It was too late to help him. And the physician was in tears because she said, you know, I should have really protested and called Child Protective Services up in Albany. So this sense of you know, the balance of respecting patients' wishes, but also knowing what's probably best for them and making recommendations and doing your best, but in the heel of the hunt, as the Irish say, you know, they'll do what they want.
Yeah, I guess I'd say it's always a challenge for facilitators when people want to jump into our cognitive heads and think about what, you know, was there something we could have done better, sort of moving into the quality improvement realm of what could we have done, what should we have done. And it's a facilitation challenge. I know you addressed this, Steph, in the facilitation workshops and training sessions, because people are more inclined to not want to feel the pain of their feelings, but to try to jump to what should have been done instead. So you might want to comment about that. But I'll also mention that we'll have on our website, I don't know if it's posted yet, a video from the dinner, our annual dinner, in which a group from Yale talked about this program they have in which they engage moms like this in taking care of the baby while the baby is undergoing withdrawal in the NICU. Very, very powerful program and a powerful video as well. It may not yet be available, but I suspect it will be up within the coming weeks. But
I think it is. It's either on our website or on our Facebook page. I saw it posted somewhere. Yep. And we can actually send it along in the follow-up email to this webinar. It is very powerful. And I think speaks to one of the other questions that came up here, which is, you know, I think a lot of times what we see in these cases is that a lack of compassion can come from a lack of understanding. So one of our participants actually asked, this is for you, Beth, I think, how successful were sites at educating the audience or the participants in the Schwartz Rounds about the issues pertaining to substance use disorders and the opioid epidemic?
Yeah, it's hard to say. It's hard to answer that because I'm not sure what's meant by the word educating in this regard. I mean, our goal was to have open conversations really about our feelings, and especially about social stigma associated with these kinds of illnesses, and to help people reframe this as a chronic, frequently relapsing disease, just like diabetes, like heart failure. When people, may not be able to adhere to whatever, the recommendations have been, they pop back into the hospitals. They're readmitted in much the same way people with substance use disorders are. And really, it's the rate of readmission for people with substance use disorders is not different, really. If anything, it's the same, if not just a speck better. At least it was when this was last studied, than people with chronic diseases like heart failure and diabetes and asthma. So, I think the goals were not to educate people about how to take care of folks with this kind of disease or illness, but rather to help us think about what is it that's so incredibly challenging. The emotions that surround the care of patients with this kind of problem they're so intense. They're very, very intense. And then when you are aware, if you're aware that you're judging, then you start becoming judgmental of yourself. So it's a question of how do you sustain your self-compassion, let alone your compassion for others in the midst of all the conflicting emotions you're experiencing. So in terms of providing educational space, I would call it reflection space, which is really the goal of the rounds. I felt that it was very helpful. Seems that the evaluations would bear that out.
Yeah, thank you. I have another comment in from a participant that this is really interesting, actually. So when we put together the national rounds sort of facilitation guide, as many of you know, we offered a standardized patient case which members were free to choose to use for the national round sessions. And I have one comment here that says, our institution did this Schwartz Rounds and used the standardized patient. We'd used it because we couldn't find a patient willing to speak at that time. The standardized patient was very helpful, and we had a committee member act out the part. Did others find, quote, real patients more or less or as powerful as the standardized case? So that's interesting. I don't know of any members who had patients speak at Schwartz Rounds, although Beth, maybe you do. But I'd love to hear one from Beth. Do you have a sense of how many institutions chose to use the standardized patient versus the sample case versus a real case? And Stephen, I would ask you also, what was it like for you to find a case to use for your rounds?
Well, I guess I'll jump. So I'm not sure of any sites in which a patient actually came to speak. And, we created the case for folks. The case was a story. It was a patient's story, her own narrative from her voice, composite from many people I've encountered, and then a provider dialogue amongst 3-4 providers talking about this particular patient. And then, people could read it aloud, sort of just read the script. It's kind of like medical readers theater. And but I don't know, because we didn't ask how many people used that instead of a case from their own, communities. I don't know. I suspect the majority use their own local cases.
Yeah.
So I don't know. I don't know about the.
Yeah, I was curious too. I attended quite a few of these rounds, and they were all very moving. They all used. No one was lacking for cases, I think, which speaks to why we launched this in the first place. Stephen, was it hard for your team to identify a case?
Well, it's interesting. We've never actually used a patient in the Schwartz Rounds. We've always had about three clinicians, a nurse, a social worker, a physician, sometimes a child life specialist, whatever. But no, we didn't have a hard time because there's so much of it around here. And we could have gone many, many different directions institutionally at the different clinical settings, but because Schwartz Rounds is facilitated through the Children's Hospital, we went with this particular case.
I remember someone commenting to me when I visited that there'd been such an influx of these cases in the sort of in mom and baby, which they were so unaccustomed to previous, 6 months or a year prior, that they felt like there was something they needed to respond to there, which is really heartbreaking, but speaks to the relevance of the conversation. And I think we have time for, it's 3:50, we have time for one more question, which is...
Steph, there's people responding to that one question here about what we've just been talking about. I don't know if you can see all of these.
Oh, yeah, I do. Thank you, everyone. Fantastic. A little dialogue. Thanks for noticing that. It's below the fold for me. So, fantastic. We have one comment where a hospital, one of our members in New Hampshire, thank you for sharing, did have rounds about babies who were suffering withdrawal, and the medical provider on the panel did share video clips of a mom. And that same member says that they have used patients in some rounds, but not this one. And I would say maybe we have to have an office hours about using patients, inviting patients and family members to participate in rounds, because that's a very common question that I hear. And people do it not frequently, but if you're interested in hearing more, reach out to me. And then two more comments. One, we often use real patients in rounds, so I would love to talk to you about that. And a clinic physician chose several cases from a practice and another member organization to discuss. A member of the panel did have an SUD history, and the physician had asked that person to join the conversation. And the perspective this person added was invaluable to attendees. I can imagine how brave that person was to participate. Thank you for sharing that. And then one last comment, if we can answer this in, 4 minutes, Beth, is we have a comment from a medical center in Illinois who held a session in January on this topic. It was well received and covered many of the areas that we've covered in this presentation. But one area we haven't yet discussed was that of drug diversion when our own employees have an SUD, and how that adds complexity to the dynamic. Are there any thoughts on that?
This is so hard. It's really about how do you deal with impairment amongst one of your own. When one of your own employees has this kind of problem, and gosh, I mean, it's hard, and it has to usually be addressed by employee assistance programs. So there are guidelines. Most organizations have guidelines around this. I think the difficulty for colleagues and peers is trying to deal with the conflict that gets evoked when you feel like you may be taking someone's job away for reporting that person, versus I need to safeguard patients, safety, and I need to safeguard this person's safety as well. If I care about this person, what's the best thing to do here? So the internal conflict is incredibly complicated about reporting a peer, protecting the safety of that individual, as well as perhaps the safety of the patients and the team members, depending on what that person's role was on the team. So it's complex, and honestly, it's a topic to be discussed, I think, within organizations about who can help with something like this, and whether to do a rounds on this is another whole question. How do you deal with the impaired colleague, the impaired physician, nurse, whoever that may be? It's very hard. It's very, very hard. I have had this experience before where somebody I was working with was diverting my own prescriptions, and oh my goodness, it takes a toll, because you do feel that your trust has been violated, your trust in that person. So it's painful. It's painful. I don't have an easy answer for this, just, you know, to get other people involved, particularly the EAP.
You know better than to look for an easy answer, Beth, right? But thank you for trying. No, that's fantastic. I want to thank everyone. I want to let everyone get back to their day, but I want to thank everyone for joining us today. I want to thank our wonderful panelists, Dr. Beth Lown and Dr. Stephen Post, for sharing the outcomes of this really wonderful, powerful initiative and your experiences with it. I'm sorry to those of you whose questions we didn't get to, but if you do have any questions or wish to follow up, feel free to reach out to me or to Beth, and we'd love to continue this conversation with our members. We suspect this initiative will be evergreen for some time to come. One last note, I would just ask that when you leave the session, if you could please complete the survey. We'd love to hear your feedback and any ideas you have for future office hours webinars. And then finally, one little plug is that we have 2 Schwartz Rounds facilitation workshops coming up in the new year, which we're very excited about. We will be in Austin, Texas at Dell Children's for a workshop on January 26th. And then we'll be having a workshop in New York City on April 26th. And as all of you know, each of our member organizations is entitled to 2 free registrations for those full-day workshops. So we hope some of you will be able to join us. So thank you very much. Thanks for joining us today. Thank you, Beth and Stephen. And everyone have a great day.
Thanks.